Hello, everyone, and welcome. Today, we're going to dive deep into the body's incredible emergency response system. Yep, blood clotting. But how do we actually know if it's working the way it's supposed to? Well, we're about to demystify the key lab tests, PT, aPTT, thrombin time, and ACT, that give us those absolutely critical answers.
Welcome to the Bioscan Hub channel. If you're a medical lab student, you are in exactly the right place. We create these explainers to give you clear, detailed breakdowns of some really complex topics. So, if this helps you with your studies, do us a huge favor and hit that subscribe button. It really does help us make more content for you.
Okay, let's dive into this. Seriously, have you ever stopped to think about it? That amazing, life-saving process that kicks in to stop a simple paper cut from becoming a disaster? It is a genuine biological masterpiece. And today, we're not just exploring that process, but we're looking at how we, in the lab, can measure its efficiency with incredible precision. So before we can even begin to understand the tests, we have to get a handle on the system they're measuring. And that system is called the coagulation cascade. The best way to think about it is as the body's detailed blueprint for building a clot when things go wrong. At its heart, the coagulation cascade is really just a chain reaction. You've got these proteins, which we call clotting factors, that activate each other in a super specific step-by-step sequence. It's just like a domino effect, right? One domino falls and triggers the next, and then the next, until you reach that final goal, a tough, stable fibrin clot that plugs the hole. Now, this cascade isn't just one single line of dominoes. It's actually shaped more like a capital Y, made up of 3 pathways that are all connected. You've got the intrinsic pathway, which kicks off when there's damage inside a blood vessel. Then you've got the extrinsic pathway, which gets triggered by damage outside the vessel when something called tissue factor is released. It's like a big help signal from the injured tissue. Both of those paths then flow down and merge into the common pathway, which is the final sprint to creating the clot. Each test we're going to talk about is like a special window that lets us peek into one or more of these specific pathways. All right, let's start with the 2 tests you're going to see more than any others. They're almost always ordered together because, as a team, they give us a fantastic wide-angle view of the whole cascade. So let's meet the dynamic duo, PT and aPT. First up is the aPTT, which stands for Activated Partial Thromboplastin Time. This test is our main window into the intrinsic pathway and, of course, the common pathway. It checks on specific clotting factors like factor 8 and factor 9. And this is super important because a lack of those factors is what causes diseases like hemophilia A and B, which makes the aPTT an absolutely essential screening tool. Now, let's talk about when things get serious. A typical aPTT result is somewhere between 21 and 35 seconds. But if you see a result pop up that's over 70 seconds, that is a critical value. It's a huge red flag that tells you the patient's clotting system is severely impaired and they are at a very high risk for spontaneous, dangerous bleeding. So, what about the other half of our duo? That's the PT, or prothrombin time. While the aPTT is busy looking at the intrinsic side, the PT is our window into the extrinsic and common pathways. It specifically measures the factors that get activated by that tissue factor we talked about, that external injury signal. So right away, if a patient's aPTT is normal, but their PT is long, it points you directly to a problem in this specific area. And this slide just lays it all out so perfectly. You can see how they complement each other, especially for monitoring drug therapy. On the left, you've got the fast-acting anticoagulant heparin, which we monitor with the aPTT because it mainly impacts the intrinsic pathway. And on the right, you've got the oral anticoagulant warfarin, which we monitor with the PT because it impacts the extrinsic pathway. They're looking at different sets of factors, which is exactly why you need both tests to really see the whole picture. And this is where it all comes together. This is where you get to be a lab detective. By looking at the patterns of these 2 results, we can start to pinpoint exactly where a problem might be. For example, if the PT is normal, but the aPTT is long, the issue has to be isolated to the intrinsic pathway. If it's the other way around, a long PT with a normal aPTT, we know to look at the extrinsic pathway. And what if both are long? Well, then the problem has to be in the common pathway, right where they meet. See how that works? The big takeaway here is how powerful they are together. Just listen to this. When used in tandem, the aPTT and PT will detect about 95% of all coagulation defects. I mean, think about that. With just 2 tests, we can find the vast majority of potential problems. That's an incredibly efficient screening panel.
Okay, but what if both the PT times and aPTT are abnormal, pointing us toward the common pathway? Or what if we suspect a problem with the very, very last step of clotting? Well, for that, we have another test. We turn to the thrombin time.
The thrombin time, or TT, is what you'd call hyper-focused. It completely bypasses all the earlier steps in the cascade and zooms right in on that final critical conversion of fibrinogen into the actual fibrin clot. In the lab, it's pretty straightforward. We literally add thrombin directly to the patient's plasma and basically hit a stopwatch to see how long it takes to form a clot. It's a direct look at the quality and quantity of a patient's fibrinogen.
And just like the aPT, the thrombin time has a critical value we watch out for. A normal TT is pretty quick, but if you get a result that's longer than 60 seconds, that's another major red flag. It often points to a severe deficiency or even a total absence of fibrinogen, a condition called a fibrinogenemia, which makes forming a solid clot almost impossible.
All right, let's switch gears a little bit. We've talked a lot about using these tests to diagnose bleeding problems, but they are just as crucial for monitoring patients who are on drugs designed to prevent clots. And let me tell you, this is a very delicate balancing act between stopping dangerous clots and accidentally causing a bleed. So in a hospital setting, we mainly deal with two major types of anticoagulants. First, you have heparin. It's a direct-acting drug, meaning it works right away, and we monitor it using the aPTT. Then you have warfarin. It's an indirect drug because it works by stopping the liver from using vitamin K to make some of those key clotting factors. Because of that, it takes a couple of days to really kick in, and we monitor its effects using the PT, which gets reported as something called the INR. So what is the INR? It stands for International Normalized Ratio. It's just a standardized way of reporting the PT result so that a result from a lab in New York can be compared directly to one from a lab in London. And as you can see here, it's not a one-size-fits-all thing. Depending on why the patient is on warfarin, maybe to prevent a blood clot in their leg or to protect an artificial heart valve, the target INR range is different. Our job in the lab is to provide that precise number so the doctors can adjust the dose and keep that patient safely in their therapeutic window.
Before we wrap up, there is one more test worth mentioning, the ACT, or Activated Clotting Time. You can think of this as a super fast, portable version of the aPT. It's used to monitor really high doses of heparin right at the patient's bedside during situations where you need constant feedback, like in the middle of open heart surgery or at a dialysis clinic.
Okay, deep breath. We have covered a ton of information. We've looked at the pathways, the individual tests, and how they're used. So now, let's put all the pieces together into one clear picture, just like you would when you're looking at a patient's results.
So here it is. This is your mental roadmap. The aPTT is your window into the intrinsic pathway. The PT is your window into the extrinsic pathway. The thrombin time gives you that super close-up view of the final step. But the most crucial point, the real key to all of this, is that by looking at the combined results, the pattern across all the tests, you can logically figure out exactly where the problem is.
And when you're monitoring therapy, just remember this simple rule of thumb. Whether it's heparin with an aPTT or warfarin with a PT/INR, the therapeutic goal is almost always to prolong the patient's clotting time to about 2 to 2.5 times what their normal baseline would be. That's the sweet spot we're aiming for.
You know, all of this precise measurement and careful monitoring really boils down to one thing: patient safety. And this quote says it all. There is no shortcut to adequate and safe anticoagulation. The work we do in the lab providing this data is what makes that safety possible. So I'll leave you with a quick case to think about, to apply everything we've just covered. A patient is on warfarin. Their aPTT result is normal, but their PT/INR is prolonged at 2.8. So 2 questions. Is their therapy likely effective? And which specific coagulation pathway is that medication affecting? Think it through. Thanks so much for joining this explainer, and we'll see you in the next one.